Dr. Baliga here. The case scenario or multiple choice question discussed in this podcast is derived from an outstanding chapter on patient safety in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It's authored by Dr. Anjala V Tess MD, who is Associate Professor of Medicine at Harvard Medical School. She's a hospitalist in the Division of General Medicine and Primary Care, Department of Medicine at Beth Israel Deaconess Medical Center, Director of QI and Safety for GME at Beth Israel Deaconess Medical Center. During her second year as a hospitalist, she served as a Rapkin Fellow in Medical Education. She served as an Associate Program Director for the Internal Medicine Training Program, where she was in charge of quality and curriculum development. As a hospitalist, Dr. Tess currently teaches on medical wards and is Director of Education for the Hospitalist program. Dr. Eric J. Alper, MD, is Professor of Medicine at UMass Medical School. He completed his medical training and internal medicine at UMass Medical School. In 1996, he became the first hospitalist at UMass Medical Center and helped to create the Hospitalist program there. He was the Internal Medicine Clerkship Director from 1998 to 2007 and Patient Safety Officer for UMass Memorial Medical Center from 2003 to 2006. Multiple choice question of the day from the Patient Safety chapter in Baliga's textbook of medicine. All of the following are useful methods in conducting a root cause analysis except A. Asking providers a series of why questions, B. Determining who carried out the error and placing them on probation, C. Reviewing the charts and the orders in the case, and D. Determine whether factors from the patient level all the way up to the organization level played a role. And the answer is B. Determining who carried out the error and placing them on probation. A root cause analysis involves investigation of all possible causes of that event, even those which may not be immediately apparent. This requires careful interviews of involved staff, chart review, processes, etc. Assigning blame on individuals is not the focus of root cause analysis. Improving systems to prevent errors is the preferred outcome of root cause analysis. Root cause analysis or contributing factor analysis is a retrospective method when an individual case is investigated using a standardized approach to identify the active failures and the latent conditions that allowed the error to be propagated through the system. The goal is to move past the actions of just the individuals and understand how the system could have contributed to and failed to catch the error. Charles Vincent coined the term contributing factor analysis to describe the systematic approach institutions can take to analyze every layer within the system and whether it played a role. The contributing factors move from the front line of care, that is the patient and the provider, up through the whole system of care to the level of the healthcare organization as a whole. The first step in completing a root cause analysis is to gather data from charts and interviews of frontline providers involved with the error. Then the case timeline can be organized and contributing factors identified. The teams can then propose potential systems fixes to prevent the error from occurring again. Another method is to list all the active failures in a case and to keep asking why up to 5 times to determine the true root causes. This requires taking each active failure separately to identify all the root causes. A critical piece of root cause analysis work includes the interviews and discussions occurring in a blame-free manner with no risk of penalty or punishment to frontline providers or managers who were acting in good faith and without intent to harm. Without this culture of safety, providers will not feel comfortable sharing the true issues that are preventing work from occurring safely. Blaming and punishing frontline staff for system errors does not help us learn about our systems. First, the error is likely to occur again even if the provider involved is removed. Second, without full participation from frontline providers, the team completing the root cause analysis may draw the wrong conclusion and fix the wrong problem. That being said, in cases in which the provider is grossly negligent or knowingly fails to follow established policies and procedures, it is important that providers be held accountable. Another important tool for safety improvement is failure modes and effects analysis, as this is a prospective method, not reactive. For this method, one enumerates each step in a known process and identifies what could go wrong with each step. One then assesses the likelihood of failure of each step along with the severity of a failure at that step. This facilitates that calculates a priority score for each step to determine which are most critical to fix first. The case discussed in this podcast is derived from Baliga's textbook of internal medicine from an outstanding chapter on patient safety authored by Dr. Anjala V Tess MD, Associate Professor of Medicine at Harvard Medical School, and she is a hospitalist in the Division of General Medicine and Primary Care, Department of Medicine at Beth Israel Deaconess Medical Center, BIDMC. She is also the Director of QI and Patient Safety for GME at Beth Israel Deaconess Medical Center in Boston. During her second year as a hospitalist, she served as a Rapkin Fellow in Medical Education. During this fellowship, Dr. Tess created a model to teach quality improvement to residents. She served as an Associate Program Director for the Internal Medicine Training Program, where she was in charge of quality and curriculum development. Dr. Tess currently teaches on the medical wards and is the Director of Education for the Hospitalist program. She has led faculty workshops in both curriculum development and patient safety education. She is currently co-director of SHM and AAIM's Quality and Safety Educators Academy. Dr. Eric J. Alper is MD FACP, SFHM, is a professor of medicine at UMass Medical School, where he also did his medical training and his internal medicine residency. In 1996, he became the first hospitalist at UMass Medical Center and helped to create the Hospitalist program there. He was the Internal Medicine Clerkship Director from 1998 to 2007 and the Patient Safety Officer for UMass Memorial Medical Center from 2003 to 2006. He is now the Vice President and the Chief Clinical Informatics Officer at UMass Memorial Healthcare. He has received multiple teaching awards and has been recognized for numerous quality and patient safety improvements.